Durban brings many memories to me because I gave the first plenary on this topic here in the year 2000 when I was still studying in England, and I was invited to speak, looking at it as a public health emergency, and I think it still is. So next slide. Oh, should I do it myself? Yeah? Okay, sorry. Yeah, so in this talk, I'll try and look at the option B plus rollout and the path to the rollout in terms of what happened, the IATT's structured support to this, the results that we're seeing, and the lessons learned, and the remaining challenges. So this is a slide that I took out of the GAP report that's going to be released at this meeting by UNAIDS, and it states the fact that option B plus has been the most widely adopted WHO guidance in countries. And I think that remains true. And you can see that when you look at this, when we launched the global plan to eliminate mother-to-child transmission in 2010, it was at a time when these discussions were happening. And part of what we had to do as the global community is also to take this on and say how we're going to support countries to do this. What I show here is what has happened up to now, and you can see that the only country in the yellow that's still implementing option B as an approach is Nigeria. But even in Nigeria, the policy has changed. In the dark blue is where we see countries really moving to national scale in terms of facilities that are providing this intervention, and in the light blue are the countries that are scaling up. Now, what has that materialized into? At the end of this, what we're trying to do in PMTCT is to make sure that what we do translates into coverage of ART into pregnant women. And what I have here is the slide way back in 2010 that tells you that in many, many countries, at that point, we were far below where we needed to be. The red actually tells us that we're less than 40% coverage in most of the countries before we introduced B+. This is 2013, and you can see that even in Africa, things were starting to change. It's not all red. Many more countries were improving cover. And when you look at the last slide, I'm sorry if you, yes, if you look at the last map there, you can see how between 2013 and 2015, things really started to change, with the dark blue looking at countries with over 80% coverage. And this is what we have now globally in terms what's being released here in terms of coverage. And you can see in many of the countries, including the global plan countries, we really have managed to achieve a lot of good coverage on ART, over 70%. We still have problems in Asia and also in Middle East and North Africa. So in terms of catalyzing this action, what actually happened? If we go back in time, really we're going back to Malawi, who in 2011, after looking at their context and what they needed to do to scale up services to women, they decided to go for a more simplified approach that was not determined by whether a woman had a CD4 count, and also to make sure that they aligned this intervention to what they were doing in the adult treatment program, where they were moving to one single pill once a day for the overall population, and they decided to adopt this for pregnant women. And if you look at the papers that have come out of Malawi, they had a lot of justification as to why pregnancy was different, why they didn't want to go with this thing, starting and stopping treatment for those women that were not eligible. And I think they convinced the policymakers, the technical people in Malawi, convinced the policymakers to do that. WHO came up with a programmatic update endorsing this approach for women, but it was not until 2013 that we had the actual guideline to move forward with this. What I'm showing on this, and I don't need to go through this, where this was the systematic approach to make sure that countries were supported to catalyze rapid adoption of these guidelines. And this is what I started off with. And you can see there by March 2011, 6 countries had adopted option B+, 16 by 2014, and 21 as of 2015, and I know that Nigeria is also moving into that direction. So these are some of the normative guidance and tools. I said we go back to 2012 when WHO adopted this guidance from Malawi. But what we did as an IATT is to immediately come up with a toolkit in 2013, before the WHO guidelines were even out, to start talking to countries because countries wanted to move into this. This was a guidance dialogue tool for countries to look at in terms of what were the key considerations they needed to think about if they wanted to move to B+. And then we had a review, I think it was in this country or maybe Tanzania, where we started to look at what were those models that were working that could apply to the majority of countries that wanted to move to B+, in terms of service delivery models to integrate ART at the lowest level of care. And then finally, we've also been looking at the monitoring has to be different. Cohort monitoring, retention monitoring, and that's just a guidance tool that has come out of the IATT again to support countries to do this effectively. So apart from this, I just want to highlight a few things that happened. A lot of countries were grappling on how do they move to the low coverage like they were seeing in Cameroon at the time in 2012, where they were only at 19% coverage of ART. How do they look at this systematically? And I talked about option B+. Just to say that as Cameroon has been implementing, they've adopted almost 68% of the guidance that we said, the checklist that we had, that they had to look at for a quality program. And you can see that that's already translating to high coverage from 19% to 61% coverage ART in that country. Tanzania developed a protocol, again, using the option B+ toolkit, and we were involved as an IATT, CDC, UNICEF, WHO, were involved in the initial early evaluation of the program there to see what could happen. Things happened very quickly in Tanzania. There were massive scale up in 2013 as soon as the protocol was done. At the end of the year, of that year, they decided to look in and see what they needed to switch and tweak. And there are some results from Tanzania that I'll share. And then for Zambia, cost was very important. They were just about to do their global plan application, and they wanted to know what will this take. And they used a phased approach where they wanted rapid acceleration, look in, and then push forward with the intervention after that. This is just to show you the work that the IATT did. This was a meeting in Johannesburg where we actually called all the countries into one room to say they needed to have costed plans and they needed to think about how option B+ would affect the costing of those plans. This is the Cameroon story that I've already talked about, but I just want to draw your attention to what happened in Cameroon in terms of the massive rollout that they had, and between 2012 and 2015, they moved from 19% coverage of ART to 61% coverage. And this is the study that I talked about, the early assessment of the rollout in 2013 in Tanzania that highlighted the 36% loss to follow-up at 3 months after ART initiation. They were experiencing massive stockouts in many of the facilities because of the unanticipated volume of women that were coming to those facilities demanding for these services, and then there were issues related to monitoring and reporting. And Tanzania is looking at all those things to try and improve the program performance. So just very quickly in terms of lessons learned, I think I'm right in saying that option B+ has facilitated rapid scale-up of maternal ART in most of the early adopter countries. And I have an example from Malawi, and this is data that we collect annually through the UN system, looking at what is happening in terms of coverage in the specific countries. In the light blue is ART coverage. Ignore everything else and just look at ART coverage and what has happened in this country since adoption of option B+. I don't have to explain the massive scale up that has happened since they adopted option B+ in 2011. The same thing for Uganda. You can see there that after adopting option B plus in 2012, in the light blue again, you can see the massive acceleration in access to ART in that country. The lesson learned with this, in terms of what we are seeing, is that unless we are people-centered, in this case, we want to make sure we reach mothers where they are, we're not going to get there. So simplifying approaches to a level where you can deliver an intervention at the lowest scale of the unit is very important. We're also learning from the retention issues that we have that we need to do more than just capacitating the facilities, that we need to do a better job at coordinating structural support to mothers, especially at the community level. The service delivery models are also critically important. I haven't talked about the issues around task shifting and what we had to do to make sure we leverage policymakers to task shift delivery of ART to the lowest cadre of staff within the primary health facilities. And all this comes with political will. And when you look at what has happened in Uganda, I think that that's a true demonstration of leadership and will to get the scale up to happen. Now, apart from this, we know that ART coverage, and we've always known, is not the only game to reduce mother-to-child transmission. We came up with a 4-pronged strategy for PMTCT, and it still remains relevant. We also know that retention in care is something that remains as an issue that requires the shifts in programming that I talked about, including community facility linkages for better support to mothers. What I tried to do here, I know it's a crowded slide, is to look at, in terms of adoption of the B+, and relating that to the reductions that we're seeing in transmission risk. The countries in the green are the ones where we're seeing over 75% reduction in mother-to-child transmission, and then the ones in the middle are below that. The ones in the red is where really we still have a lot of children still getting infected. What I did on the other side is to look at what point did these countries actually adopt the B+ regimen. And you can see that Malawi, although being the first to move forward with option B+ in 2011, they're not in the green in terms of the reduction in mother-to-child transmission. And that's a demonstration of maybe a number of factors. One, the system constraints still remain relevant, even if you've adopted option B+. But the other issues in terms of incident infection in pregnant women, the ability to which we can maintain women in care, because what I have here is the final transmission reduction impacting reduction in new infections in children. So you can see there that, in fact, a lot of the ones in the green did not adopt option B+ until 2014. So there was, you can say, maybe later adopters, and yet they're high up there. But these are countries with good systems like South Africa, Botswana, that were way out there even before we started the option B+ program. As I said, the cascade remains an issue in terms of retention in care, and we still need to look at this in terms of what we need to do to support women. And this, I again come back to 2010, 2013, and just to bring you back to say that MTCT rates are improving. When you look at the map on the right, which is the MTCT rates in 2010 and what we have now. But I just want to illustrate that we want to be in the green. And even though we've done very well in adopting option B+, many countries are nowhere near getting to where they need to be in terms of the final mother-to-child transmission. And I've mentioned a number of things that we need to do to actually support that. So in terms of ongoing challenges then, women are still testing too late, and you can see here data from Vietnam from a recent interagency meeting that was held in that region, that up to 50% of women in Vietnam, for example, are only tested in labor and delivery. And there's a reason for that, because in this particular population, a lot of these women are marginalized women that are key populations. And so unless we reach out to them and we have a differentiated response to make sure we reach out to these women, we're not going to get there. The early loss to follow-up and long-term retention in care is an issue. Coordinated community structures for support, and I'm very happy that at this conference, there's a number of community fora trying to look at how do we form coalitions, how do we coordinate these efforts for them to be much more impactful. Poor models of care to migrant families, mobile and key population is still an issue. The poor cohort monitoring to systems to track mothers and babies, and poor management, supply management systems. With that, thank you very much. I just want to acknowledge a number of people, and thank you.